Hi there, everyone. My name is Pam Yankeelove, and I'm the Director of Research and Evaluation at the University of Louisville Traeger Institute. And we are proud to present with the Kentucky Coalition for Healthy Community Project Echo Care of Older Adults. We just want to go over very briefly some technology tips. We do ask that if you have the capacity to turn on your video, please do that. It just helps with our learning environment and getting to know one another. We do ask to check your microphone to see if it's working, and then go on and mute yourself. If you want to talk, you're welcome to unmute, or you could go on and use the chat. Many of us are looking in the chat to see if there's any comments, so we'll be doing that as well. If you are having any difficulty with your sound or your video, just click on the arrow next to the microphone to test your system. If you happen to get locked out on your computer or can't get back in, you can always call in, and there is the number. You can do it through the Zoom app, or you can go on and just call in and with the meeting ID. It's also on your agenda if you have access to that. So for those of you guys who are unfamiliar with Project Echo, I'm going to give you a little overview of that. But before we do that, we were wondering if we could go on and hear from Mona Huff to hear about the mission of the Kentucky Coalition for Healthy Communities. Is Mona here?
Mona is still having issues logging in.
Okay. All right. So I'll go on and go through. The Kentucky Coalition for Healthy Communities works in partnership with the Traeger Institute to present this Project Echo. And the Community Coalition for Healthy Communities focuses on creating community support systems for older adults in partnership with existing local coalition organizations. Their idea is to develop the workforce and concerned community members to empower our communities to become healthier. So we're focused on both the micro and the macro here, focusing on looking at, very closely on a particular patient, trying to integrate the didactic that we're going to have into the patient that we're going to learn about, and we'll learn together as a team, as well as to bring it to our communities. So for those of you guys who are new to Project Echo was founded by an MD by the name of Sanji Arora from the University of New Mexico about 15 to 16 years ago. And he's a hepatitis C expert. He was actually having patients drive 200 to 300 miles to actually see him for his expertise in that arena. He realized that he really wasn't creating local capacity. So he decided to develop this telementoring program called Project Echo. And Project Echo is actually around the world on lots of different topics. The idea is to move knowledge, not patients, and to build that local capacity. It does focus on case-based learning. So we're going to have a didactic, then we're going to have a case, and then we're going to work together as a team, kind of a learn all, teach all kind of environment, so that we can understand the best practices in interdisciplinary team-based care. So we do ask that you go on and type your name and your organization in the chat box. I believe that several of you guys have started that. So I'm going to go on and do that myself. And if you could do that, it helps all of us to get a sense of who is actually here and what organizations you're from, and just helps with the overall, I can spell institute, overall learning community. And if you haven't done so as yet, we also ask you to go and put your name under your little video square, your Hollywood square. You can go on and click on the 3 little dots in the upper right-hand corner of your video or your square. Click on it, and there'll be a dialog box that presents. It says rename. You can click on rename and then type your name, your organization, and even your pronouns. So today, the presenter has nothing to disclose. We did want to let you know that we have also gotten some CEUs, 1.5 CEUs approved for certified community health workers. And we're going to share, I think, in the next slide how you can make sure you get that. Yeah, so we are providing a certificate, an attendance certificate for today's meeting for all who are interested in receiving that. In particular, for our community health workers, we are asking that you complete the community health worker evaluation. So at the end of the hour, we will have 2 separate evaluations, one specific for the community health workers to help you earn that 1.5 CEUs towards your certification, and then we'll have a Zoom poll for everyone else. So we're going to go on and make sure that we share that at the end of the hour, so all of the different parties get to the right evaluation form. And today we have a didactic presentation by Norma Thomas. The title is Implementing Cultural Responsive Healthcare Services for Latinx Hispanic clients. And so let me just tell you a little bit about Norma. Norma Thomas is a bilingual psychotherapist and assessor at Sura Mental Wellness LLC. Norma Thomas has over 20 years of experience in providing mental health services to diverse populations, including immigrants and refugees. And we are very glad to have Norma with us today. Very grateful to Norma. For several years, Norma has presenting wonderful presentations to our paraprofessional and professional students. And now we've been able to invite her into Project Echo for all of our community and professional learners to also reap the rewards from Norma. So Norma, thank you so much. And whenever you're ready, I will turn my mic off.
Thank you very much. I appreciate it. So let me share this now. Okay, so today, let's see. I'm trying to get the slideshow going. And
right. Yes. You look like you were just on it. Let's see. It says, yeah, they go to the slideshow.
And I go from
Here you go. Did it not work from that? Let's see. You go right there. Maybe, let's see down here along the bottom.
Okay, there we go.
Got it. Okay, got it. Thank you.
Oh, thank you. So today we're looking at implementing culturally responsive healthcare services. And among the things that we're doing is reviewing the class standards, considering the sensitivity to intersectional Latinx characteristics, operationalizing those culturally responsive practices that we learn about, and looking at the community resources available in our area, and then the conclusion. So the session objectives include identifying 2 to 3 guidelines provided by the class standards for promoting health equity for individuals with limited English proficiency. The other objective is to describe concepts of acculturative stress and Ulysses syndrome. I don't know if anyone's heard of that. And in relation to immigrant individuals and families. And third is to identify 1 to 3 organizations in Louisville that could be helpful resources for clients to address their basic needs and concrete stressors. So the question that we have is, in what ways can employing the class standards blueprint enable me as a practitioner to address healthcare disparities and achieve improved client outcomes in the Latinx community? And so the first thing we need to look at is the issue relating to cultural competence, which involves a combination of awareness, knowledge, skills, attitudes, and behaviors that, when applied in a healthcare setting, result in a beneficial outcome, maximally beneficial outcome for both the patient and the provider. When you're looking at cultural competence, it also involves learning new patterns of behavior that, when applied appropriately in different settings, again, involve the taking into consideration the cultural beliefs, behaviors, and needs presented by clients, and being able to distinguish what's ours and what's theirs and how we can best help. So when looking at cultural humility, you're looking at 3 tenets, which is the lifelong learning and critical self-reflection, recognizing and challenging the power imbalance inherent in the clinician-client relationship, and creating partnerships and maintaining them with other organizations and holding institutions accountable. So one of the first issues that we have to consider is that when we look at linguistically isolated households, Latinx families account for about 60.8% of them. And that is equivalent to about 2.5 million folks living in homes where no household member above the age of 13 years of age speaks English. So just imagine going into a foreign country, living in a household where you are unable to communicate, and there's no one in the household that communicates in the language of the host country either. So that's what we're looking at. And the other is when we're looking at insurance coverage, about 16% of the share of overall US population lacks health insurance. Whereas when you're looking at the Latinx population, it's about 31%. So nearly 2.5 times the share of the overall US population of uninsured folks. So when we're looking at the national, the class standards, it really stands for National Culturally and Linguistically Appropriate Services Standards. So we use national class standards for short, and those were developed back in 2000 and expanded in 2013. And they were created for the purposes of providing culturally and linguistically appropriate services. And they were developed by the Office of Minority Health to serve as a blueprint for healthcare organizations when attempting to pursue health equity for all. So there are 15 standards that are provided in the class standards. The numbers have varied. What we're going to be focusing on more is the communication and language assistance aspect. And the endeavors of the national class standards are to advance health equity, improve the quality of the healthcare services provided, and eliminate healthcare disparities. So it's an attempt to address social determinants of health. And in relation to that particular section of language, language access would mean that there's language assistance services, such as interpreter services or bilingual staff, that are provided at no cost to the individual with limited English proficiency at all points of contact in a timely manner during all hours of operation, which means that it's not just at the point of contact with the healthcare provider, but at all different points of contact with the organization. Then there's the notification of rights, which involves verbal offers and written notices informing patients of the non-discrimination policy and their right to receive language assistance services and language access and grievance procedures, but in their preferred language. So putting up a notice that is in a language that they cannot read, code is not helpful. It would have to be a sign or a notification in a language that they can understand. And then when looking at the availability of interpreters, it's assurance of competence of language assistance provided to the individuals by interpreters and bilingual staff, and avoidance of use of family and friends for those services except on request by client. This is difficult because there are costs involved and expenses involved, but basically the rules are if an organization is receiving federal funding for providing healthcare services, then it is the duty of that organization to also provide interpreter services if needed. The availability of materials, which would have to be the materials shared as in intake forms, consent forms, and so forth, are to be easily understood client-related materials and post signage. And again, in the languages of the commonly encountered groups or groups represented in the service area. In this case, we're referring to the Latinx population. So when you're looking at operationalizing culturally responsive practices, you're looking at the total patient experience and satisfaction, which then affects the clinical tasks in which we are managing or working on, and the patient outcomes. In practical terms, we're looking at staff buy-in, because if you're looking at all touch points, then it would not only be the medical providers or the healthcare providers, but everyone in the organization. And that would also mean building a sense of compassion and care into all client touch points, which leads to a milieu environment that contributes to healing. So there are many different ways of going about operationalizing these practices to be culturally responsive. One of them is recruitment. And with regard to Latinx folks, it's the most underrepresented major minority group in the US healthcare workforce. And to give you a number, here's your pie of physicians, and only 5%, which you can see is a very thin sliver, is comprised by Latinx physicians. And if you look at other healthcare providers, the numbers are even smaller. So when you're looking at an underrepresented major minority group, you're also looking at multiple linguistic and cultural barriers between patients and the healthcare providers. So ideally, there's a recruitment and retention policy for a diverse workforce, and also using data-informed and evidence-based strategies to accelerate that process of recruitment, hiring, onboarding, and development. But then there's also the skill development, the development of knowledge, attitudes, awareness, and sensitivity that then translate that information into tangible practitioner knowledge that can be consistently applied and assessed in healthcare encounters. So here are some ways of using, for example, biopsychosocial lens in treatment, and using an interdisciplinary healthcare professional team development, and quality improvement through the integration focused organizational efforts. And then there's also the promotores de la salud, or the healthcare navigators. So those are frontline public health workers who are trusted members of and or have an unusually close understanding of the community served. These are not necessarily healthcare workers in themselves, but they are the links between the healthcare space and the community. So they assist individuals to adopt healthy behaviors. They advocate for health needs by facilitating effective communication with different agencies, and implement programs that affect positively the community health. And they can work as part of medical teams in hospitals or in-home care as necessary. The other way is provision of interpreter services. So one is the I Speak poster or I Speak card. And here it's when you have an organization where people from different backgrounds show up and you're unsure about which language they may be speaking in, you can show them the card and point. But of course, there's the issue of illiteracy. If a person cannot decode the written word, this may not work. And the other is when you have many multiple languages, if the font becomes unreadable, then it's not useful. The other is a more practical one, which is an individual carrying a card in their wallet, in which they can indicate that their preferred language of communication is maybe their native language, in this case, Spanish. And then the individual can present these cards at healthcare setting encounters or other government agency organizations, enabling then the folks that are working there to facilitate the process of obtaining interpreter services. Then there are posters that can be placed on the premises, indicating that that language assistance is available for them. Again, this is in keeping with the class standards. So just remember, when considering the encounters in healthcare settings, that the common values include the courtesy and politeness of simpatía. The personalismo has to do with warm personal interactions. So not very hurried, even though we're in a hurry. This is a hurried world. Respeto, and just considering that they will show you respect because you are considered as a healthcare provider an authority figure. Familismo, so there's that collective loyalty and obligation to family above all else in many instances. And fatalismo, which is the belief in inalterability of fate. So you'll have these words that people will say, but that's usually tied to, just resigning yourself to the idea of what is. So in major decisions, you're looking at different family members being involved. So that can present challenges in maintaining privacy standards. And in two-parent households, usually the mother decides if therapy, for example, will be necessary, but the eldest male is the one that usually makes the ultimate decision. And so in considering these things, it might be useful to consider pursuing additional training in family-centered treatment and care models. So when making first appointments, consider inquiring who's accompanying the client to session and preparing accordingly. And when using interpreters, you have to consider building time into the appointment schedule, because an hour of usual English speaking clients will not be an hour with an interpreter in the session. And remember also that people of Latinx cultures, depending on their level of acculturation, often do not take on active roles in communication during interaction with healthcare providers. They may nod. There's that silence. And that does not necessarily mean acceptance of treatment. It usually means deference to the authority figure showing you respect. So acculturative stress, this is an important factor in consideration. It emerges when an immigrant encounters cultural conflicts perceived as problematic. And the process of acculturation alienates person from traditional supportive primary groups, and also facilitates internalization of host society cultural norms, such as, damaging stereotypes and prejudicial attitudes. So the image on the left is supposed to represent people living in the shadows, meaning people who are undocumented and who don't appear in the registers anywhere. So in the term Ulysses syndrome, it was named after Ulysses. If anyone can recall from school, it was a legendary Greek hero, also known as Odysseus, who fought in the Greek and Trojan War. He was a king, and then he had this long journey home that is accounted in the book of the Odyssey. He had many difficulties and challenges. So that's why the Ulysses syndrome used his name to explain the condition where the Ulysses syndrome is supposed to be a gateway between mental health and mental disorder. And it tries to explain that the symptoms that the individual is presenting with and the responses to extreme situations of chronic and multiple stressors can sometimes or often exceed the adaptation capacities of the individual. So if you have someone living in the shadows, permanently alone or unable to see family again because they are unable to get back, living in fear of returning to homeland, etc., there is a point where if this ongoing stress finds no resolution, the individual can cross into the limits of illness. So feeling these stressors isn't necessarily illness, it's the person trying to cope. But when these stressors are ongoing, then it could cross into that territory. So the Ulysses scale was created by Joseba Achotegui, considers migratory griefs. He originally conceived 7 types of grief and then added an additional 8th. But he conceived it for use in psychosocial or preventative health care rather than treatment. So it's looking at the resilience factors and the stressors and trying to ameliorate the stressors with the hope that that will help the individual rebound. So the protective factors that you might find in many Latinx families is that sense of social responsibility, strong family relationships, and family traditionalism. So when addressing concrete stressors, you're looking at the systemic barriers that impact the different aspects of a person's identity. And when we're looking at culturally sensitive healthcare needs, you're looking at incorporating services and resources to remove these barriers. If assisting a family first with concrete solutions to difficulties of daily living, and you look to case management, what has been found is that those folks are 4 times more likely to access healthcare services with decreased health problems and experience improvement in health status than immigrants who did not receive such services, meaning addressing the concrete stressors in their lives. So referrals to support groups and community resources where the client and family can connect helps to decrease alienation. And in relation to undocumented individuals and families, it's documenting instances of trauma and effects on the client, which provides resources for seeking legal remedy if applicable, and considering the factors that could jeopardize their capacity for adjusting their immigration status, which would be another session. So when looking at community resources that could be helpful in addressing the needs of our Latinx individuals and families, we're looking at in resettlement agencies here in Louisville. One is the Catholic Charities of Louisville, and they address many different types of immigration services, such as family reunification and those applications, asylum cases, these different cases. That is for folks who are looking to adjust their immigration status or citizenship. So all these things are very important. They're a great stressor for many families. So if you are aware and you can connect them to these resources, that would be very helpful in ameliorating that issue. Another agency is another of the services that they provide is the Common Earth Grounds, where they can garden and grow produce that they can take home, and language services such as interpreters and translation services of documents. Let's see. And then there's the Kentucky Refugee Ministries. Many of their services overlap in some ways. With these agencies, you'd have to check from time to time because it depends on funding, but they do help with many things such as employment, immigration and citizenship, and so forth. And then there's the Americana that has other programs such as out-of-school time youth programs, family support, adult education. So for English ESL classes, English for second language learners, adults, they're very helpful. And then these other programs that they have as well. And then there's the Jewish Family and Career Services. So for individuals who are struggling with finding work or being able to translate some of their ideas into a viable small business, JFCS helps navigate those processes and helps them to acquire or establish one. And then the other important one is La Casita Center. They primarily focus on undocumented folks and other folks who may need, for example, food, diaper bank, soup kitchen, and then other support groups. So this organization is a go-to for many of these services that that are not offered by other agencies. And then there's La Clínica Preston, which is on Norton. It's a Norton Community Medical Associates. So this is 100% practice, bilingual practice, open in North Carolina. And this one is one where, as I had mentioned earlier, the different touch points, from the moment you call to the moment you leave, there's always someone that's able to speak in their language, in Spanish. So folks feel great contacting and being serviced, receiving services there. So they're very busy. It's a very busy practice with long waits, but it's because of that. There's Park Duval, and the reason I refer folks there is because of the drug pricing program. So individuals who don't have insurance are able to get medications at a significantly lower cost. So, so the question in the end is, in what ways can employing the class standards blueprint enable me as a practitioner to address healthcare disparities and achieve improved client outcomes in the Latinx community? I'm guessing that with the case that's going to be presented, you can better address that question. But basically what Ignacio Martín Baró mentioned, or one of his sayings was that as social scientists, our fundamental preoccupation should be less on explaining the world that exists and more so on transforming it. And that's basically what I have on this subject.
Thank you, Norma. That was amazing. Thank you so much. You got through all your slides, didn't you? I had to blink there at the end at the reference. It was such great information that was coming at it. Thank you so much for helping us with our cultural humility journey with Latinx and Hispanic clients. Thank you for going through all those resources and giving us the specifics about what each one can offer, what their specialty is. This is the time where we can have any questions. Any questions or comments? Things that you've learned, you can either put it in the chat. But any questions, anything that you'd like? We have a few minutes for questions, about 3 or 4, and we can definitely ask Norma to expand on anything or reiterate something that you'd like her to.
Yeah, this is Christian. I just wanted, I think you said this is a federal law that now, says that anybody that gets federal money has to have an interpreter. So is everybody using I think our health system uses one interpreter, but is it like one service that's used, through all these different, or is there a lot of individual private services everybody's using?
Well, so for example, if you needed a live interpreter, an interpreter in the office, you could resort to Catholic Charities or Kentucky Refugee Ministries. Sometimes people will resort to the language line type of service where you just dial and get a person online because of the convenience. There's certain convenience attached to that, in the sense that you don't have to prepay service an interpreter upfront for time that they may not be able to serve, because the patient may not make it and you still have to pay the interpreter for that time. When you use a language line, you may not have to. But yes, it's either that, or even when, let's say, Catholic Charities or Kentucky Refugee Ministries may not have one available on the date that you need, they can refer you to others that are working independently.
Yeah, I think U of L Hospital, the way they did it, it was like you would have it would like a Zoom. It would be an in-person through Zoom interpreter. Do a lot of people use that, or is it mostly just the phone, or both?
Well, that came about because of COVID. In the past, it would be always someone in the room. They would be contracted to show up. But with COVID, then we got used to, okay, the person can show up through Zoom, and then you are able to still use the service without having the person come personally to the office.
Yeah. Yeah, it's interesting how things have changed, but it seems like it's easier to access than it used to be in the past.
Yes.
I don't know, that's just my opinion, but it's great resources. I think, yeah, I didn't know that you'd get Catholic Charities and people would come in person. So that's something we'll have to pursue at our office. Yeah, that's helpful.
And I think that thank you for that. Liz put in the chat that last year, the International Rescue Committee opened as a Louisville's third refugee resettlement agency. Let's see.
Yes.
Yes, okay. And then there's a question from Mary. Are agencies actually penalized for not providing the service?
Well, they can be. So everyone who receives federal funding is supposed to do it. But let's say, for example, a small organization with limited resources, it may be very difficult. So there are provisions for showing hardship to the organization in providing interpreter services. But bigger organizations are expected and can be penalized for not providing interpreter services when needed, especially. So in one of the other sessions, we looked at the issue of what has happened in some instances where appropriate interpreter services were not used and there was medical malpractice. And so sometimes they're not penalized directly for not having interpreter services, but the lawsuits end up costing the organization many thousands of dollars, if not millions in some instances.
Mm-hmm. Yes. Okay. I think that thank you so much, Norma. I think at this time, what we're going to do is we're going to move to our case, and then Norma's going to stay with us, everyone, and help us through some of the recommendations with the case. And if there's additional time at the end, Norma might have a few comments too. All right. So Beth Pace is going to be presenting our case. The recommendations are going to be taken by
me.
Oh,
Dr.
thank you,
Sam.
Sam. Thank you, Dr. Sam Cotton. All righty. So we have Beth Pace. Let's see. I don't see.
Yes, I'm here.
Yet. Oh, hi, Beth. All
Yeah.
right. So whenever you're ready.
All right. Thank you, Norma. That was very informative as always. And I just really appreciate the perspective that you bring. I know for me personally, I was a student last year. Well, I'm still a student and working at the Traeger Institute, but sometimes having that baseline information is really helpful. But then this is a good example of when I was kind of thrust into a situation that I was not prepared for. So anyway, I'm just going to be sharing with you all with some vulnerability here, like what I felt like was a situation that we really could have done better to support this family. And I think honestly that we have done better since this initial visit. So that's good. But this case was here. I'll just give a little bit of an overview. We had a Spanish speaking patient and her daughter come in for an orientation appointment for the brain health clinic. And so that first visit usually involves a pretty significant, like a pretty large packet of paperwork that usually is completed by the caregiver or a family member. I didn't know ahead of time. I don't know if the medical staff knew ahead of time that these women were only Spanish speaking. But when they got there, it felt like a little bit of a kind of a shuffle to figure out what to do. Obviously, like we were not prepared with Spanish versions of all those forms. So there was like one out of the whole thing that I could find quickly. I immediately tried to like see if those Spanish versions were out there. And they weren't. And so what we ended up doing was using the language line to go through the paperwork, which was definitely not ideal. I'll get into that a little bit more. But basically the questions we're trying to address are how can we be better prepared to serve our Spanish speaking clients, and what steps should have been taken to protect the patient from potential embarrassment or discomfort. So the patient I mentioned was there for a brain health appointment. So she was dealing with cognitive impairment and memory loss. I'm not sure if she's been formally diagnosed with Alzheimer's disease, but that was the primary reason why they were there for that appointment. I don't know if you normally, yeah, okay. I didn't think I needed to go through all those details. So the patient's daughter reported issues with memory loss since 2015 to 2016 with gradual progression. We were able to get a little bit of background using the language line from the daughter to find out that the patient functions independently with some things like walking, transferring, and feeding, but requires assistance with going to the bathroom and is dependent on others for all of her IADLs. So this patient is from Cuba, and she has family in Cuba and some here in the United States, and had traveled back and forth since 2013, but earlier this year came to live in the United States permanently. Her family provides transportation, and it does not, to my knowledge, appear that she has a POA or advanced directives. And then I'm not sure about the other issues, the economic stability or education. So currently the patient lives with her grandson who works from home. I think from my understanding, the reasoning behind that is just for supervision. The family did not feel comfortable with her being home alone. So one daughter still lives in Cuba and was her primary caregiver, and plans to relocate to the US. And at that point, they would move in together and she would resume those caregiving responsibilities. But it does seem that the patient has a strong family support. So as far as these health behaviors, the patient's daughter does report that the patient smokes. I think they try to keep her from doing that, but that she does still smoke. She's prescribed with donepezil. Is that how you say that? Which is for Alzheimer's or dementia. And no known issues with her eating habits, physical activities, or medication adherence. Part of all the no known issues is kind of part of the problem, right? Like part of the issue that we're trying to approach is that there is, it's a challenge to get a full grasp on the situation with the language barrier, especially with my involvement, which was very brief, and just that first appointment, it was just very limited. So I think there's a few slides that I did not have any information on. Okay. Yeah, so the patient's family is involved and seems supportive of her. And then the providers that were involved were Dr. Gums and Meredith Mendez, who run the brain health clinic at the Traeger Institute Optimal Aging Clinic. I think they have been better equipped these last few appointments with the language line. But that first visit was the biggest problem, just because of all the documents that needed to be filled out. And is that the last slide, Justin? yeah, so. Okay, yeah. So I wanted to just give y'all a little bit more information about how that, just kind of tell you the story of how that day went, so that I can get your feedback. Basically, we decided to use the language line to try to get through the paperwork, and it was kind of a disaster, as you might imagine. Like looking back, I feel like I should have anticipated this. I was not super familiar with the paperwork, exactly what the questions were. But as we got into it, the three of us are in there together, the patient, her daughter, and me on the phone with the interpreter, and having to ask just really kind of some of the questions on those forms. They're trying to get a feel for how much help the patient needs, what they're able to do, and just things that can be embarrassing to talk about out loud in front of the person. That's why the caregiver or the family member is usually just kind of privately filling those things out. So after a few minutes, the patient seemed to be getting kind of agitated, and I just decided it was probably, we had done enough and needed to just stop. So I went and got Dr. Gomes, and the paperwork didn't get completed, but she was able to come in and talk with the patient and her daughter using that language line. And I think with a little bit more sensitivity to the delicate nature of some of the topics. So that's kind of the gist of it.
Thank you. Thank you,
Yeah.
Beth, for sharing
Sure.
that. And it's going to be a really good learning opportunity for all of us. Yeah, so is there any comments? There's lots of things I think we can begin on. How can we better be prepared to serve our Spanish speaking clients? There seems like many areas.
Yeah.
Right. Does anybody want to jump in? So
This is Christian. I'm sorry. This is Christian. I was just going to say, Beth, I mean, I think you did a good job of stopping, right? Realizing like this is embarrassing. It's not going well. Some people just power through and it just goes from bad to worse, So at least you were sensitive enough to like stop. But, going back to the first presentation, you're right. If we know ahead of time, a lot of times we get the language line with the doctor, but like the front desk needs the language line when they check in, and you need it all the way through the whole process. So it really brings up a lot of areas where we're lacking.
Mm-hmm.
And I'll just say, just from the medical standpoint, you did say it right, donepezil, that's Aricept. And I think since she's on that medicine, that is the medicine for dementia. Probably they officially diagnosed her and put her on medicine to treat her dementia. So I think she probably is officially diagnosed with dementia. She's on the Aricept.
Right.
So how do we usually find out if our patient, has limited English proficiency in advance?
I don't think we do, right? I mean, I don't know. That's like the $1 million question. I don't know. Does anybody else have any ideas? I don't think we know.
I do think I noticed later that I do think there is a place that can be flagged in Epic. I'm trying to remember exactly what that is, and I don't remember. I should have been.
Well, I think to add to that, Beth, I think we should be using the Post-it notes in Epic for that kind of stuff.
Yeah.
I think it might be helpful because you can see like a little flag comes up for you when you're a person in Epic looking at the patient's chart, and you should really always be clicking on that if there's a flag, because that can help you kind of know those sorts of things.
And that's the blue, right? Isn't the blue sticky note?
Yeah, I think yellow is just for you as the person. Like if you wanted to make a note, oh, this person's son or daughter's name is this, so you remembered it like at the next appointment. But blue, the whole team sees.
Yeah.
Right.
And so moving forward, to have translated materials, do we send out, or do we, when we send our information for appointments, should we always be making sure that it's written in English and written in Spanish, or asking if it needs to be in a different language to send that back to us? Because, when you always, when you call a customer service line, there's always that, if you need a different language, you sometimes think about how when individuals get their documentation in advance to complete, that is there in the message if you need a different, or is it just translated when the person uses their computer and they use their Google Translate or whatever it is, which we know isn't great to do in a best practice perspective.
Can I also add something? And maybe Miss Norma can give us some insight on this. Sometimes we have patients, well, I have not experienced this in our clinic, but I have been a patient of another clinic, and I have witnessed where family members are interpreting or translating for their loved one at the appointment. And I obviously know, based on having sat through Miss Norma's didactics in the past with our students, that's not obviously best practice. So if you're in those situations, I have witnessed this. I've been a patient, so it's been kind of like an awkward situation. But if you're ever a professional seeing this, how would you kind of approach that situation? Is there like best practice for like dealing with that if you see it happening? Like, what are some things we can do to help?
This is Liz Edgel. I work at Family Health Centers Americana, where we serve lots of refugees and immigrants. And we have a friends and family waiver form so that we always offer an interpreter and explain that they have a right to an interpreter and that we will provide it at no cost to them. And if they choose still to use their family member as an interpreter, which sometimes they do, then that's okay. And they sign that waiver form for us so that we have it on file, and we explain that we talk to them about it. We use an interpreter to explain that right to them. And then I always train our providers that really you still have the right to get your own interpreter if you ever feel like the family member's not interpreting well, or they're using, they're not all trained. You could be bilingual and not have mental health or medical vocabulary. So that we can always say, I'm sorry, I'm having trouble understanding, or I want to make sure, like, this is my job. I want to make sure that I'm clearly communicating and really understanding. So I'm going to add an interpreter to this mix and add one. So I think that's really important.
Mhm.
Thank you, Liz. That's helpful.
Yes. I think there's might be a question or a comment. Sierra, let's see. There's a few. So Sierra, you guys do the same thing with early intervention services. And then Krissa, how did the patient schedule the appointment? If the patient scheduled the appointment using a Spanish line, that should flag.
That's what I was wondering, because whoever made the appointment, I mean, did they know that this was a Spanish speaking patient? And if so, then that would have been like, hey, call the office, tell us. So I think that's an internal thing. Like, a lot of our appointments are made by our access center. So I need to follow up with the access center, and they need to be asking, right, if it's Spanish or any other language. Then we could have sent all those forms. I mean, those forms were all in Spanish, I think. So we could have sent them ahead of time in Spanish.
Mhm.
I don't know. Is there a Spanish line where they can make an appointment? I don't exactly know.
That's a great question. And I've had some confusion. I don't know how we find out how an appointment was made, if that's something that we have access to in Epic somewhere.
Yes, Kat could show you, or Meredith or somebody could show you. You can tell who makes the appointment. Yeah.
Okay, great.
Does the area where the appointment is made, are those folks the ones that send out the forms or send links to the forms?
I'm not 100% sure about that. I should know that, but I don't know.
I think it's the access center. So if you're through U of L Health, now I know we have a lot of organizations on the call, and probably every organization does it differently, but this is a patient of our clinic, and I think the access center sends out those forms. And I do know we've talked about this extensively in some of our other grant related meetings. That there are consent forms and the patient packet, not the one in their my chart. So if they go to my chart, that might be a struggle for them to navigate. But those actual things that are sent out to the patient when they're a new patient can be in Spanish as well, as well as their consent forms.
Mm-hmm.
I think typically this particular packet is usually given to them when they get there for the appointment, rather than being sent ahead of time. And Dr. Furman, I may be wrong, but I don't think, at least at this point, this was several months ago, so I hope that this has been resolved, but I don't think these forms we have in Spanish, which was part of the problem. I don't know if anything's been done about that. It's like all the questionnaires about, you know, I ADLs and ADLs and what kind of assistance they're needing and what kind of memory challenges you're seeing as a family member, that kind of thing. I don't know the names of all of them, but
Well, that's something that we have to work through on our brain health. There's enough Spanish speaking people that I think, but yeah, that's a good point.
yeah, I wonder too about just even, I thought surely within the university there's resources for translation, I would just assume, but I don't know.
Yeah, at U of L Hospital, there's in-person Spanish interpreters. And I think we can get the in-person Spanish interpreter over to our clinic. I mean, it's not that far away. It's like 2 blocks. I think they would walk over. But all the other languages, it's pretty much just the language line. And
Okay.
yeah, you're right. They could translate.
So let me ask this. There's a few other comments. Is Lafayette here? Do you want to ask your question live?
Hey, Dr. Yankee,
Hey, Lafayette. Hey there.
my question was really just if the forms are translated to Spanish and sent out, how are they being translated back into English, right? I don't know if that would necessitate a whole other position to make sure they're translated. And then, when you have someone translate something to a family member, I often wonder if the information is filtered in a way so that, it doesn't have the highest fidelity for what you're asking. So, if I understood the question, I asked my dad and he said something that maybe I didn't want to share, we're not going to assume that that's what happened, but it is a possibility. How do you make sure you're getting what you need, the answers that you need for care?
Right. Good question. Liz, did you want to say something about that?
Yeah, sorry, I was starting to type and I accidentally forgot it was going to go. Yeah, we're coming across more Spanish speakers who do not read in Spanish either. So I just wanted to throw that out there. I think that's just like our American-born population. We're not always cognizant of who reads well and who doesn't, but we are just coming across higher numbers of people that we're recognizing aren't able to read in Spanish. So I just wanted to throw that out there, that translation may not always get you where you're trying to go as far as efficiency. And then my other thought was paperwork culture. I just think that's a really US concept to go and get handed paperwork. And it's, even my husband and his mom, who are from the Caribbean, they're English speaking, and my husband's been here 20 years, but he has me go to his medical appointments, and as soon as any paperwork is handed out, he hands it to me. So I just think we're really, that's such a US culture thing to do all this paperwork. So that's hard. And I know we don't have a perfect answer. I just wanted to make sure everybody's cognizant of that discomfort that people have with paperwork in general. And so sometimes having an in-person interpreter for an intake visit or something where there's going to be a lot of paperwork is worth the effort, so that the interpreter might help them and assist them in actually filling it out if your staff doesn't have time to do it with an interpreter on the phone. So that's just one thought there. And also, while you're talking about the patient scheduling part, just to have folks ask, what language do you prefer for your visit? That's a really good way to capture it. You don't want to say, do you speak English or do you need an interpreter? Because sometimes people feel like there's judgment in that. So we're not perfect, but we try to get our patient access folks to ask that question just of everyone. What language do you prefer to speak at your appointment? And that way you can flag it in your system and make sure you have interpreters when possible.
Thank you. Thank you, Liz, for sharing that as well. Norma,
that's a really great point. I just want to say about I think making the assumption that everybody reads the language that they speak. So yeah, being aware of that, I think that's something we can do a better job of as well. So I appreciate that comment.
And Norma, do you have any comments about anything to say about Lafayette's question about the translation of forms and then the retranslation of the form, how that works in practice?
So, I mean, I do that myself with forms. I might use some check boxes here and there to help the individual who's completing the forms have some idea of what we're looking for, and then blanks for them to fill in. And But yes, it might be that once the form gets back from the individual, if it's completed electronically or even on paper, if they send it back, it may be that you might need a
You cut out.
art if you're not using an interpreter at the time of, because there's a cost associated with using interpreters. And so that's the issue. You're trying to weigh the cost of the use of a professional with some of the more mundane tasks of going through paperwork. On the other hand, some of this information may be vital. So then you might need one at the time of, let's say, the visit, to be able to go through the paperwork and review what was written.
Thank you. And then Justin, you had a comment or question?
This sort of refers back to Lafayette's question, because the Kentucky Most Coalition experienced this a few years ago. We started being asked by several health systems about having the Kentucky Most form. If you're not familiar with it, it is an advanced care planning tool. And basically, we were trying to get the form in Spanish, and there were lots of questions about this. And in my naivety, I thought that I was going to be able to just contact the Kentucky Board of Medical Board and get feedback about it. And it turns out that wasn't the case. But that was what we ended up coming up against, is if, even after we translated it into Spanish, we needed to have it in Spanish and in English. So both the family and their healthcare surrogate and the healthcare provider could understand it. And really, it took a lot of support to find different organizations that had found an easy way to communicate this. So we ended up partnering with a group in California to get some instruction on this. So, I mean, it's like I recognize just a single form can be complicated, but much less a questionnaire that's really in depth. I mean, there's a lot of skill that needs to go into these different moving pieces. And at least in Kentucky, it doesn't seem like we have real easy structures that kind of streamline this.
Yes. And then, yes, there's some comments about interpreters and the expense. Yeah, many healthcare systems have budgets for their interpreting and translation services, and they are required, as Norma was saying, if you're receiving federal funds, you are required to have those. So you should incorporate that into your budget. Let's see, so Beth, moving forward, do you feel better about some of the things that you're gonna get the health system to put in place, or you and your colleagues in that space to be able to make the patient and their family feel less embarrassed and more comfortable in that space?
Yeah, I think just from a personal perspective, being better equipped so it doesn't feel like a scramble to figure out what to do, that was not ideal. So being more prepared ahead of time, I think reevaluating the forms that we are requiring to see, like, is all of that necessary? I know there's certain documentation that they have to have for this type of appointment. But can we limit it to what's just necessary and try to get the, maybe even just having a translator in person for that first appointment to make sure that all the groundwork is very clear. Because I think moving forward with the follow-up appointments, using the interpretation line would have been sufficient. Not ideal as much as having somebody in person to interpret, but yeah, I think maybe taking advantage of that in-person interpreter for the first appointment could be a good kind of way to lay the foundation, and maybe just have that expectation that we can plan ahead for if we know that people are Spanish speaking.
Yes, thank you. And I was just wondering if Norma, in the last minute before we transition to our Kentucky Coalition for Healthy Communities, if you had a concluding thought or anything additional that you wanted to share with us.
Well, it's the issue that the Latinx population is very diverse. So you also have the issue of acculturation. And so, for example, for some folks, completing a form may be a drudgery because they're not used to it, and or because of literacy issues. Then there are others who are very comfortable completing them on their phones. So the idea is being able to ask up front if they have comfort with completing forms and what language they would like the forms in. So sometimes the caregiver is more comfortable completing a form in English because their level of acculturation is greater. And so when they're helping out their parent, they're like, I don't want the form in Spanish. It's too hard for me. So it's being able to adjust our expectations to what the patient or client is telling us about their needs. So there is some value in the forms because it also gets them primed for the event, the encounter. They know what we're looking for. They know what it's some idea of what we're going to be asking about. On the other hand, depending on literacy, comfort with paperwork, and so forth, it may or may not happen beforehand. And so then it's being prepared with vital documents, such as consent forms and so forth. That may be a major dread for people to look through. So then I might send it up front to read, and then we might review it again when we meet in person. So it's that kind of thing. It's being able to adjust depending on what our patients are telling us.
Thank you. That was a great conclusion. Thank you so much, everyone. And thank you, Norma, for sharing all of that great information. And Justin will, within 24 to 40 hours, share the MP4 of the videotaping of our didactic today by Norma. So something we can watch over and over again and continue to learn. So thank you again, as we now are going to transition to our Kentucky Coalition for Healthy Communities time of our meeting. And I believe that Mona's with us. And I'm going to pass the mic to Mona. I can't actually see Mona. Is Mona with us?
So Mona is on her phone, and so I'm just I'll talk about the KCHC purpose. So again, the KCHC's purpose is to train and empower stakeholders and community members to provide hope and education for their communities. So if anybody has anything they'd like to share today about upcoming events or anything that you're concerned about, now is an opportunity to do that. Anything that anybody has anything coming up that they'd like to share? Also, anything you'd like to share about how you're going to take this information either back to your community or to your organizations? Something that stands out to me is just knowing about this process of how we make sure we need to, have forms that are, in multiple languages, and being able to access the appropriate translation services is really important, something that I could stand to learn more about. Anybody else have anything they'd like to take back to their organizations or their communities?
There's all the things that we can do to prevent that discomfort in that meeting, the things that we can do in the sense of looking to see what language is preferred for the forms, or if they like forms, or and getting things completed in advance would be something to prevent this discomfort and those types of things.
And Aisha said that they learned how to address other cultures that don't speak English. Yeah, I think that's a really good place to start. Anything else that stood out to you that you'd like to take back to your communities or your organization? Okay, Mona, are you able to unmute to talk about the walk with your doc and the county walk? Okay, well,
Okay, well, that's okay. While Mona's maybe trying to unmute, I can talk a little bit about this. So Walk with the Doc is going to be held the first Saturday every month at 9 o'clock. The location is at the Henry County Recreational and Services Park, which is in Newcastle, Kentucky. We've included a link there, so you can go to the link for more information. Our lead physician on this is Dr. Claudio Moisa. If you haven't worked with him before, he's fantastic. We really enjoy our partnership with him. You can email Mona if you have more information about that. And walking is obviously one of the best things that you can do for your health. It is amazing, the studies that you see about how just taking a few steps a day and trying to increase those to get up to what the American Heart Association says is the standard of the 10,000 steps a day, how much it is that can do for your overall health. So this is a way for you to be able to join in and maybe start working on those walking goals.
thank you, Erica. And a fun fact, if you did not know this, you can now access hyperlinks through Zoom sharing. I think if somebody would like to click on these links, you should be able to access them from the screen, which is kind of a neat trick.
I attempted to, and I'm not having success, but it could be just me.
Okay, well, then maybe it is because I am sharing the PowerPoint. Okay, so this is something we need to go back and learn about because it's able to do it on my end. So that's good to know. Okay, so it's not working. So I will make sure that when I follow up anything that's in here that doesn't have a QR code, I will make sure to email after the meeting. So if you're ever interested in Walk with the Doc, I will share that information when I follow up in the email after today's session. So Erica, do you want to talk about the County Walk Challenge?
Absolutely. So every year we have an annual county walk challenge, and this is where the counties in Kentucky challenge one another to see who can get in the most steps during the month of September. And we make it as easy as we possibly can. A lot of counties form their own teams. We've had libraries that participate together. We've had health departments that participate together, but essentially they put together teams and keep track of their steps. And we do this every year. Like I said, it's in September. This was our 12th year of being able to do it, and we just concluded. And Justin, if you go to the next slide. All right, so I'm happy to announce the winners that we have this year. For large counties, Jefferson County came in first with 326,579 steps. For medium-sized county, Oldham County won with over 11 million steps. For small counties, Henry won. I believe we had Henry as the winner as well last year. They walked over 1 million steps. So our total number of steps was over 21 million steps. And if you can look and see how many it was that we did in 2022, we blew the goal completely and totally out of the water, which was completely awesome. And look forward to having even more success when we do this again in 2024. Again, it was a very easy thing to be able to participate in. Anybody who has a smartwatch or an app on your phone, or even one of those good old pedometers, you're able to put that on, keep track of your steps, you enter in your information, and then we award a trophy to the winner.
And do we have a representative for Oldham County or Henry County on the call?
Hi there, my name is Peyton. I'm the representative for Oldham County. I work at the health department. I'm currently the epidemiologist here, and this is my second year participating in the County Walk Challenge, and I'm excited that we are able to have the trophy this year. So thank you for hosting this and sharing all the valuable information on social media. We tried to share everything that we saw, but yeah, overall a great opportunity. Absolutely, we'll do it again next year, and hopefully we'll keep the #1 spot.
Yeah.
Thank you guys.
Congratulations, Oldham County.
Peyton, I don't know the difference in size between Jefferson and Oldham, but I'm a little embarrassed to be the representative from Jefferson County. I need to step it up. I'll be here all day, folks. Do we have a representative from Henry County?
I work at the North Central District Health Department. We cover 3 other counties, but we cover Henry as well. So I was shocked to see that they won. So one of our counties won. So that's great. And thank you for letting us participate. Me and my coworkers, most of us are housed in the Shelby County office. So we made sure to get out and walk too. But thank you guys. We appreciate that and can't wait for next year.
Thank you. We really appreciate your all support and your participation. I think we can all agree that, September is a great time to get out and walk in Kentucky. It's cooling off a little bit, and we had a couple of really nice days in the fall. Eric, anything else with the county walk?
No, we will continue. We will step it back up and have those meetings again. We'll just keep the puns continuing here. Next year, probably about January, we'll start talking about this again. Where a lot of you have given us the idea of trying to have some sort of statewide partnership. We will be looking into that to see if we can't make that a reality. But we were thrilled with the participation that we had this year and the numbers that got turned in and the groups that participated together as libraries and as extension offices was amazing to see. So thanks to everyone for all the work that you did, all the information that you spread, and we look forward to seeing you next year.
So Brenda asked, does the Oldham County Walk get promoted through the health department on Facebook?
It does. So we work with a variety of partners here in our county. We work a lot with the library and our health department mainly. But this year we did something new. We ordered yard signs with the QR code, and we posted those not only on our health department property, but I don't know if you've ever been to LaGrange, but one of our biggest attractions is Commerce Parkway. We have a sidewalk, and so we posted these yard signs along the sidewalk. We get tons of walkers there and posted them at the parks, at the schools. And so anybody who is walking, we ask them to scan the QR code, save the link on their phone, and report their steps at the end of the month. And so I largely think that that's where a lot of our success came from. So if you guys haven't done that, I would recommend it. We got a pack of like 10 signs on Amazon, and it was pretty affordable. So I think that's one of the reasons we won. But
yeah. I will also say the Oldham County Public Library really turned out. They had a large group of walkers who walked together as a team, and they turned in just a little over 6 million steps from the number of walkers with the library. So it was awesome.
That's great to know. Thank you.
Mm-hmm.
Well, thank you, everyone. And Mona, I apologize that you're having issues with your sound. We really appreciate all the work that you've put into coordinating everyone in the county walks. So just a few ongoing programs the Traeger Institute offers. And again, you can always share any events that are that you're having in your communities as well. We have My Health Matters on Monday nights, and this is the upcoming schedule for October and November. And then some of our programs that we offer here at the Traeger Institute, Flourishing Together, which starts back in January. Our Flourish program, which includes community health navigation and evaluating around social determinants of health. Our caregiver program, I think whenever you signed your registration for today's session, you clicked whether or not you were a caregiver. If you ever need caregiver support, please let us know and we can get you some more information. And then our virtual friendly visitors program. So we offer lots of programming here at the Traeger Institute, and you can always either contact myself or Mona, and we will get you connected to the right resources. So we really appreciate that. You're reaching out, and if any interest you might have. Our Optimal Aging Conference is in April. We have our call for presentations open now through October 31st. I think this presentation today in this meeting really highlighted the need for health equity. And our conference in 2024 is going to be focused on aging and health equity. So if you have a presentation or a topic that you would like to present, hint, hint, Norma, I think you have lots of great information, and I'm sure there's many of you that are doing projects and have information that you would like to share as well. We invite you to submit a proposal for the Optimal Aging Conference in 2024. We're going to be in person here in Louisville, Kentucky, at the Brown, I almost said the Brown Theater. We were at the Brown Hotel. But if you have any questions about that, you can contact myself or Erica Osborne. And again, that deadline for the call for presentations is October 31st. So just a reminder, we are our pledge is to become an effective state coalition working with community members and community-based organizations to empower our state to become a healthier and compassionate people. We will practice self-care and model healthy behaviors to our families, coworkers, and other members of our community. So we do really appreciate you being here. as we get into the fall, let's appreciate some of this time to, celebrate the natural beauty and use it as a time for reflection, and reminding us of the cycle of life. If you are a community health worker and you would like to receive continuing education, I am going to put the link in the chat, and you can also use the QR code here on the screen. So I'm going to invite you, if you're a community health worker and you would like to receive a certificate today for 1.5 hours, please complete that evaluation. I'm going to leave that in, that'll be in the chat so you can access it there. Everyone else, I'm going to ask you to complete. So Sam, I am unable to launch the poll if you're still on. So Mona, are you on? Is there any way you could launch the poll?
Is it that you don't have the poll along the bottom? Yeah, I don't either.
Because Sam logged in, it screwed up my ability to launch the poll for some reason.
She became the host.
Yeah, something happened. So I am going to leave this up here. I'm just going to invite everybody to just complete the community health worker evaluation. And if you don't need a certificate, please just put NA where there's a line for your community health worker number, and maybe you can put it in the bottom. I don't need a certificate, or I'm not a community health worker. And I do apologize for the technology issue, but I'm just going to ask everyone if you could complete the evaluation. And I hope you will join us in November for a presentation on integrating behavioral health into primary care. And then in December, we're going to be putting person-centered decision-making into practice. And note that the December session is on the second Friday of the month instead of the traditional third. So I will hang out if you have any questions. I'm going to put that evaluation link up here, and I'm going to go ahead and stop the recording. And if we don't